Hi guys, thanks for all coming out. Thanks for sticking around. I am getting very sick, so if I start to trail off, just wave your hands and let me know. That if you can't hear me, I'll try and speak up, make sure I got the laser. So I'm going to talk to you about radioembolization. Now obviously Dr. Kim and Dr. Schlachter already kind of went over a lot of transarterial therapies. Particularly Dr. Schlachter talked a lot about clinical trials and kind of comparing TACE and Y90 and other modalities of treatment. So I'm not going to, I knew I couldn't kind of hold a candle to their talks. And so I thought when I looked at kind of the title for what we wanted to talk about, lessons learned, I thought I'd think about kind of the lessons I learned and kind of developing myself as an interventional radiologist, my career, and working with patients, and specifically doing Y90 cases, radioembolization cases. And so I thought my talk I'd center more on kind of the arcane details of what goes into a Y90 treatment, and then kind of where the pitfalls can come up all along that process. Because I think as an interventionalist, and I don't mean to be dismissive, but I feel like when we're talking about a chemoembolization or an ablation, I think of it as a procedure. I go in, I put the needle in, I burn it, I pull the needle out, and it's done. Or the chemoembolization, I know where I need to go, I put my catheter in, I inject the agent, and I pull it out, and patients generally do really well afterwards. Y90, on the other hand, I think of it as a process. There are multiple stages to it. There are lots of kind of pitfalls, things you really have to be careful about. You really have to select your patients well. And I think there's a lot more room for error, and it takes a lot of skill and a lot of wisdom, I think, to really do these cases well and to treat patients well. And I've definitely learned a lot in my years doing radioembolization cases. And so I thought I'd kind of take people through the process, because a lot of the probably arcane details of the procedure are not immediately obvious to those who aren't doing these procedures every day. I don't have any disclosures to discuss. So first, I just talk about the treatment rationale for TARE, transarterial radioembolization, talk about patient selection, go through the technique, talk about the complexity of the dosimetry calculations, and then talk about kind of the side effects and complications, and a little bit on clinical outcomes. I think a few slides on the data and the comparisons have already been repeated or produced tenfold by Dr. Schlachter and Dr. Kim, so I won't spend too much time on that. So transarterial radioembolization is hepatic intraarterial injection of the radioisotope Y90 to treat unresectable HCC. Y90 is a beta emitter with a half-life of 64 hours with a tissue penetration of, we usually think about a centimeter. It's incorporated into two different kinds of beads that we use. There are two different brands out there. ThareSphere, as Dr. Schlachter also kind of mentioned, is made of glass, and then the SearSpheres are made of resin. Microsphere diameter, they're both very, very small, and so overall, no matter which agent you use, the term embolization, while technically correct, is probably a bit of a misnomer in terms of kind of what popular understanding of these procedures are. Because chemoembolization, you're trying to shut down the blood flow, kind of stop the tumor, close up the artery, and get kind of an end point with that. Whereas with the radioembolization, it's really not that at all. You're just depositing these little particles with the radioisotope in them to basically deliver brachytherapy. So it's basically an internal radiation source, and should really be thought of as a form of brachytherapy. And in fact, if you actually embolize the vessel to the point where you're cutting off blood flow, that's actually not what you want to do. One, because sometimes it can be very dangerous, and we'll talk about that from a technical point of view, but also the way radiation inflicts its damage is by free radical formation. And so you need the area that you're wishing to treat with radiation to have oxygen exposure. And so by cutting off the blood flow, I think some people theorize that you can actually dampen or hamper the therapeutic effect that you wish to achieve. So anyway, we talk about this as really as a form of brachytherapy, and there are lots of comparisons to the way, I guess, maybe things used to be done or still are in certain circumstances when you compare internal radiation versus external radiation, trying to treat the liver externally with external beam radiation. When you do radioembolization, you can generally achieve a safe administration of a therapeutically high radiation dose, up to 150 gray oftentimes, with a lower risk of radiation-induced liver damage and other complications than you might get with external beam radiation, which would actually be delivered at a much lower dose and still bring kind of different problems and complications that can come with external radiation. So the high tumoricidal doses of the Y90 are achieved by preferential deposit of the particles in the tumor due to differential perfusion. So that means, normal liver obviously gets a large majority of its blood flow from the portal vein, so maybe 75%, and arterial flow about 25%. The convenient thing about liver cancer, HCC, is that as it grows and goes beyond a centimeter in diameter, the blood flow, the supply to it, basically parasitizes arterial flow. And so you get much, much more arterial flow and much less portal flow, to the point where some tumors probably have almost exclusively arterial flow. And not only that, when you're looking at the arterial tree of the liver, there'll be increased capacitance, decreased resistance to flow. So you'll see when you inject dye, tumors will light up because there's preferential flow to these tumors, decreased resistance. And so you can take advantage of those flow dynamics to direct your injected agent to the areas that you wish to treat. And it's the same as with chemoembolization or radioembolization. The one key difference, and I'll kind of go into this more, is that, as Dr. Kim mentioned, we are very, very good at being very, very selective with chemoembolization, selecting, beyond subsegmental arteries to embolize tumors very specifically. Typically, the way radioembolization, the way the treatment is designed and the way we perform it, you're doing less selective embolizations, you're doing segmental treatments, you're doing lobar treatments, even whole liver treatments. And so you're exposing the entire liver or entire part of the liver to this radiation dose, but you hope you aim to kind of get more of that agent into the tumors. And so we take advantage of this differential perfusion that allows us to kind of achieve that effect. So when we're doing treatments, as I mentioned, you can do whole liver treatments. Obviously, what we're doing is exposing the entire liver to a certain extent to radiation. And so I'll go through this a lot more, but you really need to select patients well. You need to be very, very careful about treating their entire liver with radiation when you're really, wishing that you could just treat the tumors. So to treat someone's entire liver at once can be very risky, but sometimes it's clinically appropriate, and sometimes the way their anatomy is, it's kind of what you have to do. Commonly, we do lobar treatments, right or left. There are some centers out there, and I think we'd like to do this more, where you're doing more segmental treatments, what we call radiation segmentectomy sometimes, when the tumors you wish to treat are small enough and isolated to, like individual segments or segments of the tumor, of the liver that you can kind of, select. We can do things sequentially, so if you want to treat multiple segments or both lobes of the liver, you can kind of, do them in piecemeal sequential fashion. And sometimes, if you really have a good effect, maybe or maybe not, but the patient tolerates the procedure well, or if they get new tumors and you want to go back and retreat again, sometimes you can do retreatment, but again, you have to be very careful when you're dosing an entire part or entire liver with radiation. So patient selection is very, very important. I think, again, I don't mean to simplify chemoembolization, but I feel like lots of times when we look at patients for chemoembolization, we look at their disease burden and we can basically decide, yes, that this is appropriate for the patient. There are very few things apart from, kidney function and, making sure the liver function's okay before we can go forward with the treatment. Whereas with radioembolization, there are a lot more things that are involved, and I'll go through those now. Basically, you want to make sure that apart from the disease burden being appropriate for the treatment, that the patient is not going to, suffer or even die from the treatment. So we look at their biochemical profile, and we also look much more, I think, carefully at the performance status than we might for an ablation or a chemoembolization. Classically, the HCC that ends up being treated with Y90, at least more so here at Yale, is the unresectable, the large, the infiltrative disease, the tumors that we don't think we could possibly cover adequately or safely with a chemoembolization, tumors that are well beyond ablation, the reach of ablation or resection. Lots of times, though, even though the tumor may be diffuse, we still need the patient to have a good amount of underlying, functional liver. So we like the patient to have, about at least 70% of liver that's uninvolved. Less than 70% of the liver involved, at least 30% of the liver that's uninvolved. We like the patient, we like to make sure the patient has reasonable liver function, so we look at total bilirubin. We like that to be 2 or less. They need to have good synthetic function, so albumin 3 grams, per deciliter or better, and also normal INR. All of these speaking to just kind of good liver health. Their functional performance their performance status is also quite important. We like patients to have an ECOG score of 0 or 1, and 2, we definitely screen those patients very carefully. Any patients that had prior kind of biliary interventions, bile duct stents, any kind of, and even like sphincterotomies, anything that's kind of where they've had manipulations of the biliary tree, where they might be more predisposed to having enteric bacteria reflux in the biliary tree, you have to be very, very careful about the radioembolization because their infection risks and complications from those infections will be much greater. Portal vein patency. So remember, obviously you all know how important portal vein flow is to the liver. And when we're doing a chemoembolization, if we're going to be cutting off arterial flow to an area, hopefully we're just being very focal in a tumor. Sometimes it's not so easy to do that. We like to be sure that we have good portal vein flow so that the surrounding liver remains healthy. Whereas in radioembolization, since we are not, or at least hopefully generally not, actually cutting off blood flow to the area, the portal vein patency is not as important. And in fact, sometimes when patients actually have tumoral portal vein thrombus, Y90 is really one of the only ways we can actually hope to kind of reach that tumor and treat it. So the technique. So this is an IR suite, of course. There's a little vial of Sear Spheres, one of the brands of the Y90 beads that we use. Up on the left is kind of a case that I did probably about 2 years ago, a very infiltrative tumor in the right posterior lobe there. You can see an angiogram picture showing how the tumor looked, and also, and I'll do these in more of sequence, but we have a SPECT CT there showing the uptake in the tumor. So the way the technique works, it's nice because it's an outpatient procedure, and although there are lots of pitfalls and things you have to worry about, if you select patients right and you do the procedure well, it's a very well tolerated, very safe procedure to the point where patients can have these treatments done on an outpatient basis. But it is a kind of a complex multi-stage procedure, and so what happens first is we have to do a mapping angiogram where we bring the patient in and kind of let's see what's going on, figure everything out, where we are going to map out the vessels, going to map out where we want to treat, and then afterwards we're going to do basically a test injection of a technetium-99 MAA dose, where that will kind of simulate what we're going to do when we actually do the treatment. And so then we send the patient up afterwards, after that injection, for a SPECT CT basically to kind of evaluate, to make sure that what we're injecting is only going where we want it to go. In other words, it's not refluxing or shunting to other parts of the kind of the abdomen, the stomach, the bowel. And also patients will inevitably have some liver-lung shunting, and patients with bad HCC will tend to have worse shunting. And so if the radioisotope, too much of it passes from the arterial supply into the hepatic venous supply and then on to the heart and lungs, so you can get a pretty bad radiation pneumonitis. If you get reflux of these radioactive particles into enteric structures, the bowel, the stomach, you can get pretty bad ulcers, and those can lead to bleeding, even perforation. And unfortunately, these all, because this is radiation-induced damage to mucosa, they don't respond well to PPIs. And if you do get a really bad complication with perforation, these problems can be devastating, of course. So talking more about the mapping, the mesenteric angiogram, the goals are basically to embolize or at least deal with, or at least understand, if nothing else, the collaterals so that you can inject the particles safely in the liver. So commonly, we'll see the duodenal artery and the right gastric artery as potential avenues where if the particles reflux, we can have disastrous complications. So depending on where we're going to place our catheter, we will commonly coil embolize the GDA and the right gastric artery as a way to kind of put little caps or corks on them to protect them so that the beads can't reflux into these vessels. We're not annihilating the blood flow to these vessels because there's all sorts of robust collateralization throughout the abdomen or the abdominal arterial supply, but they're just kind of safety measures. Obviously, a lot of hepatic arterial variants are common, so we have to, again, this is one of the reasons why we map things out. Then, we also need, from a technical point of view, we need to understand what kind of catheters we're going to use, which shape catheter, which length, where are we going to put it to be able to situate it properly and select as selectively as appropriate to treat the tumor that we want to target. And so that's, sometimes that can be quite difficult because some patients' arterial anatomy can be very challenging just to get access and out to where we want to go. So it's important to plan that so you're not on the day of the procedure with this Y90 stuff sitting there and you're trying to monkey around, find your way in. And then once we kind of have that figured out, we're going to need to calculate the dose of the agent that we're going to use. And so to do that, we need to get very precise volume measurements of the liver, the lobe, the segment that we might treat, and also the tumoral volumes. So we can get information from the MRI, we can get information from other cross-sectional imaging, but commonly during these procedures we will do what's called a cone beam CT, where we're doing a CT angiogram on the table where we're just injecting a specific lobe or segment so we can really measure out precise segmental or lobar volumes. And then at the end of this procedure, like I said, we inject the technetium dose typically from the point that we plan to treat from to kind of simulate the real thing. Because what we're going to do, again, is look for, make sure we know where the particles are going, and also to measure kind of shunting. So this is just a picture of a celiac angiogram. Patient is facing us, so the patient's right is on your left of the screen. And the catheter is just, oops, sorry, wrong button. Catheter's here in the celiac artery, origin there. This is the splenic artery, this is the common hepatic. You can see the gastroduodenal artery going down. This is the proper hepatic, left and right. And this image is not the best quality, I apologize, but you can see in there somewhere perhaps the right gastric if you really squint. So these two, so you can imagine if we wanted to park our catheter right here and do, say, maybe a whole liver treatment, any reflux of particles down into the right gastric or the gastroduodenal could hit stomach or bowel, and that would be really bad. Even if we park our catheter up into the left or the right, the reflux risk is much lower, but still there. And so depending on an operator's comfort level with the procedure and or the patient's anatomy, we'll commonly embolize these. So here, we've put some coils in the right gastric artery, and this now shows the anatomy a bit better, left and right hepatic arteries, and here's the GDA still open. And then we pop this is called a plug, but basically like a nice coil. And now we've kind of occluded the right gastric and the gastroduodenal. And here we're injecting from the common hepatic artery. And you can just see now we've nicely isolated the flow to the liver. So you just want to kind of make sure you funnel the particles that you're going to inject to the area you want them to go. So then we inject the technetium, like I said, from the point that we wish to treat, and we send the patient up for basically, in our institution, we do a SPECT CT. And we're basically confirming where the dose went. What you see here nicely is deposition of the dose in the area of the liver that we wish to treat. If you remember that MRI picture, that's the tumor that we're aiming to treat. And so now, I think actually it's right there. Yeah, sorry. So we have a nice, kind of co-registration there. And you can also, this allows us to kind of calculate the volume of the right liver lobe here as well when we need that for calculation. And what you're not seeing is you're not seeing any radiotracer uptake in the stomach. You're not seeing any radiotracer uptake, well, maybe not on these images, but in the bowel. So this was a nice confirmatory set of images to make sure that we were going to be safe with this procedure. What was also done off these images, the calculation of the liver-lung shunt. So inevitably, some radioactive material will get through the arterial supply into the hepatic veins and up into the lungs. But this is not necessarily the best set of images to evaluate this, but this patient also had a very low liver-lung shunt, so it was a very permissive anatomy for us to proceed. So then talking about the dosimetry. So now, with a chemoembolization, you can just park your catheter. You start with a vial of beads and a certain dose, maybe 50 milligrams of doxorubicin, and you just try and get in as much as you can. But with the radioembolization, there's a much more complicated calculation that we need to make sure we're treating the patient with the proper dose. So we start out by, and depends, the calculations are different whether we use the THERA-spheres or the SEER-spheres. And a lot of that is because when you look at these particles, the way the THERA-spheres are produced, and these are the glass, you get 2,500 becquerels per particle, whereas the resin SEER-spheres, you get 50 becquerels per particle. And so there's a lot of kind of different dynamics involved when you're injecting these different agents, and you have to kind of plan for that and work around that. But anyway, we calculate the liver volumes and lobar and sometimes segmental volumes using whatever cross-sectional imaging means we have. Commonly, like I said, a lot of us will do cone beam CT images during the procedure to get those nice volumes. We also need to calculate the liver tumor that we wish to treat, the volume of the liver tumor, and then obviously that's going to be best seen on an MRI if we can get that. We then also calculate body surface area, and those numbers are easy to get. And then the liver-lung shunt fraction is calculated again with a nuclear medicine study done at the end of the mapping angiogram. So then, like I said, the treatment dose calculation differs depending on which product you're using. As probably many of you are aware, TharoSpheres are actually approved for HCC. SearSpheres are approved technically only for colorectal metastatic disease treatments, but we, in common use, depending on the institution, either or both can be used to treat HCC. So I won't really go into a lot of the details here, but basically just to show you that the equations are different depending on which agent you're using, the TharoSpheres or the SearSpheres. But in the end, it's globally a similar calculation, trying to kind of match the dose to the volume of the tumor you're treating relative to the overall liver volume. Now, for the SearSpheres, I'll say we work with the liver-lung shunt more kind of, I guess, actively. We measure the shunting fraction, and that will kind of determine how much we actually reduce the dose sometimes. And so here, this is a patient actually from my previous institution when I was a fellow, and we injected the dose, and you can see everything localized to the liver nicely, and there's really no appreciable uptake in the stomach or bowel for that matter, or in the lungs. This is another patient, different set of images, but you can see there's a lot of radioactivity in the lungs there. And so this shunt was well over 20%. So this is the patient where, heading into the procedure, looking at the disease burden and looking at what we saw angiographically, we thought this was going to be a straightforward treatment, but then this shunting really kind of, really curtailed this patient's treatment options. So it's very important to plan all this out. So then talking about, kind of the side effects and problems that can happen after treatment. Even if you really screen patients well, you really select your patients well, and you do a really good job, there will always be, risks for side effects and complications. So the side effects, if a patient has a successful treatment, the side effects are not that bad. Fatigue, for probably more than half the patients, they'll get it for a few weeks. Not a big deal. Usually you can just treat them symptomatically, supportively with hydration and pain medications and things like that. Low-grade abdominal pain, nausea, and vomiting, again, not too bad. Complications, obviously, are much worse. So radiation-induced GI ulcers, like I talked about, often are very refractory to conservative management and can be, devastating. Biliary complications, some series have reported up to 10% incidence of these. Dyskinesia, not such a big deal. Cholecystitis. So what I didn't really show in detail in some of those angiographic images, oftentimes the cystic artery is not being kind of excluded. And so when you're doing like a right hepatic arterial treatment, you might actually send radioactive particles into the cystic artery that's supplying the gallbladder. People have found that the incidence of radiation-induced cholecystitis versus the incidence of kind of a ischemic cholecystitis by coiling off or plugging up the cystic artery are about the same and very low. So usually we don't bother going through the exercise of coiling off the cystic artery, and instead deal with the low risk of cholecystitis afterwards. So biliary strictures, biliary necrosis, and biomas are low but significant. I mean, real risks that these patients undertake. So radiation-induced liver disease. This can be really bad. When you look at a patient, pathologically, you'll see sinusoidal congestion, venous occlusion, even hepatic fibrosis. It happens, a month or 2 months after, and it is not, that common, but it can be really difficult to predict who's going to get it, who's going to, have to deal with this problem. And there have been really no studies, no data that kind of provide any predictive model for this. And I remember I had a patient, pretty young, healthy guy, and he was kind of a snowbird, and we did his treatment, and he did really, really well. He had a great response. And then he's like, okay, I'm going to go off to Florida. I'll see you back in 6 months. And he just happened to be going to the Tampa area where one of my co-fellows is an interventional radiologist at Moffitt. And my friend called me like a month later and said, this guy is in Florida, liver failure. He basically died within 3 months. And I went back and looked through all the dose calculations, and we really, actually kind of maybe even undertreated him a little bit, and it just was something that we just never would have predicted. And he had really great liver function, great performance status. So it's a scary thing. So this is kind of like some of the things I was talking about, where we really have to select our patients well for this procedure, and even despite that, understand that these patients can have some pretty bad complications. So obviously, Dr. Schlachter and Dr. Kim, maybe a little bit also, really went through these data in a lot more detail and rigor than I could ever hope to. But basically, a lot of studies have been done. Unfortunately, it's really difficult to do randomized controlled trials, obviously, where you kind of can directly compare TACE versus radioembolization. But I think there's a lot of data out there that really support that radioembolization is at least as well tolerated as chemoembolization, and in many ways at least the same, if not superior, in terms of kind of survival outcome, treatment outcomes, and different kind of clinical endpoints. So just going through some of these studies here just very briefly. So we look at one-year survival rates of untreated HCC patients, 50% BCLC-B patients, and 25% one-year survival among more advanced stage BCLC-C patients. So Riyadh, Salem, and Northwestern, I think this study was already talked about in more detail, basically reported their results in 291 patients that were intermediate and advanced stage disease levels, and the response rates were 42% according to WHO criteria and 57% looking at EASL criteria. Their TTP was 7.9 months. The Child-Pugh A patients had a median survival, and I think Todd went over this slide, of 17.2 months. The Child-Pugh B, 7.7s, and the patients with portal thrombus, 5.6 months. And again, this study was already cited, but the outcomes between conventional TACE and actually I meant to say yes, I'm sorry. The outcomes comparing TARE, generally speaking, to conventional TACE and DEB TACE were basically equivalent. And then this other study by Sangra basically, kind of showed, again, like really good results when you're speaking in terms of, relatively speaking, in terms of comparing to other treatments for HCC, and again, with really, pretty decent results. But like I said, no clinical trials, really randomized clinical trials comparing the two. So another study put out by Riyadh Salem's group in Northwestern, it was a comparative effectiveness report, and basically described, the adverse events and the problems with radioembolization and time to progression, as well as response rates, basically a little bit better, they thought, than TACE, but with no benefit in overall survival. TARE has also been shown to perhaps be superior in terms of rates of downstaging HCC patients to transplantation. And TARE also seems, if you look at all the data, to cause less hepatotoxicity than TACE, even in patients with a TIPS in place. And again, that's kind of speaking to the portal vein, flow issue. We talked about patients with portal vein thrombus and how they can be at risk for chemoembolization. In kind of maybe a conceptually similar fashion, if a patient has a TIPS in place and a lot of the portal vein flow is being shunted from the liver, they may be more dependent on arterial perfusion. And so when they looked at patients with getting radioembolization compared to chemoembolization, not surprisingly, they found that there was probably less hepatotoxicity than with chemoembolization. And so those are my references. Basically, I think, for me, like I said, in my mind, I feel like an ablation or a chemoembolization are very, very much more straightforward, technically speaking, and I feel like when I see a patient, I can just say, yes, this tumor looks like it'll be, acceptable for this kind of treatment, and we can just bring them in, do the procedure, and kind of expect, a pretty standard kind of postoperative course and kind of risk profile. But with the radioembolization, like I said, I think there's a lot. While overall, it seems, it's been shown to be a very effective treatment, and overall, maybe even be superior in many ways to TACE. There's also a lot of room for pitfalls, a lot of better, I think more intense patient selection that needs to happen. So that's just my, just for a lot of people out there in the audience who aren't familiar with all the mechanics of the radioembolization, I thought it'd be useful to kind of explain all that. So thank you very much.